and welcome to Live Doctors. My name is Dr. Charles Siminoff and I practice as a family physician in Manchester, England. Today's discussion is on skin cancer, its diagnosis and treatment, and I'm very pleased to welcome an expert on the subject, Dr. Aton Holzer. Dr. Holzer graduated from Weill Cornell University Medical School in New York and currently practices as a dermatologist and also as a Mohs surgeon in both Miami and Tel Aviv. Hello.
Hello.
If we could have a brief outline on skin cancer, the sorts there are, and how you would recognize them.
Skin cancer, of course, cancer is the phenomenon of growth of abnormal cells and division of cells in the way that they shouldn't. Skin cancer, the most common kinds of skin cancer are cells that make up the epidermis, which is the uppermost layer of the skin. And there are three main kinds of skin cancer that people tend to get. The first is basal cell carcinoma, which is the most common form of skin cancer. There are about somewhere in the realm of 4 million of those diagnosed every year in the United States. The next most common is squamous cell carcinoma of the skin. There are about 1 million of those diagnosed every year in the U.S. And then there's about, the third is melanoma, which is the cancer of the melanocytes, which are the pigment cells of the skin. Those are far fewer. There are about 75,000 of those diagnosed every year. Of those three types of cancers, basal cell carcinomas, squamous cell carcinomas tend to grow a bit more slowly than melanomas, which tend to want to be picked up more quickly because they tend to be more aggressive. And melanomas really constitute the most deadly kind of skin cancer.
The symptoms of skin cancer, would the average individual, should they be aware of any changes or anything they should be looking out for?
Sure. As far as symptoms of skin cancer, basal cell carcinomas, squamous cell carcinomas, and melanomas all present a little bit differently. Basal cell carcinomas tend to present as what we call pearly papules. Pearly meaning they kind of look like pearls. They're a bit translucent, clear, whitish, and they have what are called telangiectasias, which are these blood vessels that are prominent that you can see. And these, often as the cancer grows, they tend to open up and start to bleed. Sometimes they form an ulcer and they bleed and they don't heal. So that's what you would look out for in a basal cell carcinoma. Squamous cell carcinomas tend to be more rough and scaly, red. They may start out sort of flat and then become more substantive. And they can also get to, as they outgrow their blood supply, they can also start to bleed, and sometimes they can itch. Often, some people have the misconception that cancers have to be painful, but most of the time, very often, skin cancers are not. And so with these sorts of cancers, patients ought to be on the lookout. Anything that's growing, that's bleeding, that hasn't been there before, that's especially something that's red, that's pearly, really is something to bring to your doctor's attention. Melanomas are classically dark. They have what are called the A, B, C, D, and E's of melanoma. A is asymmetry. Melanomas resemble benign lesions, benign moles on the skin, which which all of us have, which are flat and or sometimes raised, but typically those are symmetrical. You can fold them on on an axis, on a line. Melanomas usually are not that way. They can you can't really fold them on an axis, so they're asymmetrical. Their borders are usually rough and uneven. They call them scalloped as opposed to being round. Color, what you want to look out for in a benign mole is something that's of one color, as opposed to melanomas, which may have more than one color, which may have a dark area. Sometimes a melanoma has an area that's gray. Something that's jet black is always something to bring to your doctor's attention. A mole that you have that's changing color, also something to bring to your physician. Diameter, something that's greater than the size of a pencil eraser, 5 millimeters, is also something to keep an eye out for. And E is for evolving. If something is growing, a mole that's growing, that's changing, is always something to be on the lookout, because these are signs of melanoma.
So any change in character, colour, the roughness, you should be aware that there could be a problem there and bring it to the attention of your physician.
Exactly. And this is so important because the key to with skin cancer is potentially curable, and the key is really catching it early. If we can catch it in time, we can. If you can excise a melanoma when it's still in situ, when it's still in the epidermis, 98% of the time it's cured, and there are no further issues. The problem is once it's gone deeper, and once it's reached the lymphatics, the deeper part of the skin, that's when it becomes much more difficult to control.
Are there any high-risk groups that you would be saying to people, well, keep an eye out for, you could have problems?
Sure. As far as non-melanoma skin cancer, non-melanoma skin cancer is, of course, people who are out in the sun, people who, with all skin cancers, the greatest risk factor is exposure to ultraviolet light, ultraviolet radiation. So the sun gives us two forms of ultraviolet radiation. One is UVA and one is UVB. UVB is the kind of ultraviolet light that causes sunburns, and UVA is the kind that causes photoaging, that causes wrinkles. So there are other good reasons to avoid exposure to the sun. But those have certainly been very tightly associated with non-melanoma skin cancers, but also with melanomas as well. People who are fair-skinned tend to have melanin that doesn't work quite as well in protecting them from the effects of this ultraviolet light, and they tend to get more mutations that lead them to develop these skin cancers. So we advise people to take precautions from the sun. Don't be out if you can help it, all day from between the hours of 10 a.m. to 2 p.m. If you are, make sure you put on sunscreen at least every 2 hours. Make sure you wear sunscreen that's there's an SPF of 30 or above. Make sure that it's a sunscreen that offers protection from ultraviolet radiation and not, and that's from a reputable company. Make sure that that you wear sun protective clothing. Wear hats. Wear tight weave clothing that also protects from the rays of the sun, and a lot of common sense. Sure. in terms of sun protective practices. As far as
presumably also to avoid burning your skin.
Exactly.
Which can make you more vulnerable.
Exactly, and avoiding tanning. The people who tan, tanning is really exposure to these this ultraviolet radiation in a concentrated form. So, the short-term pleasure and beauty, supposed in the eye of the beholder. For some, really people pay the price, and people have to weigh these concerns in terms of the price that they pay with exposure to the ultraviolet radiation. And we don't know. Really, the people have asked, what is the safe level of ultraviolet exposure that I can get? And the answer is that there isn't. We don't know of a safe level of ultraviolet radiation exposure, and so the best that we can do is just keep ourselves protected.
Sure. Is there any specific age group that is more at risk?
The incidence of skin cancer does increase as people tend to get older. So there's certainly more skin cancer. They say that statistics seem to show 50% of the United States population by the age of 65 has had a non-melanoma skin cancer. The peak age for melanoma is somewhere between 50 and 60, but melanoma is also I think the number 2 cancer for people between the ages of 15 and 39. So people, even though cancer is much less, thankfully, is much less common among younger people, melanoma is still up there. So people have to be careful at every age. And people, especially with melanoma, people who have a family history of melanoma, who have a relative, certainly 2 relatives who've had melanoma, people who have many unusual moles, or people who have red hair and freckles, blue eyes, should be on the lookout. They do have an increased risk of melanoma in particular, and that's something to be aware of.
If a patient notices they have a skin change, they will come to you as the dermatologist. Can you just outline what steps you would take to check what the condition was and the tools of the trade for coming to a diagnosis?
Sure. So, I would, we would look at the lesion that the patient brought to us. Patients who are at risk for skin cancer, we would typically do a full body exam. Recommend those for patients who are at, particular risk at least once a year. Many dermatologists make use of a device called a dermatoscope. That's a kind of scope that uses lights to help us to focus in on the structures that are of the pigment cells within the skin, and even other vessels within the skin. So sometimes can tell us whether something is a benign lesion, is a mole, is maybe something that requires a biopsy. If it does look a little suspicious for something that could be a skin cancer, the next step would be to do a skin biopsy. If it's suspicious for a basal cell cancer or a squamous cell cancer, we'll often do what's called a shave biopsy, where we'll just take a sample of the uppermost layer of the skin.
And that would be done in your clinic?
In our
clinic. You wouldn't have to come into hospital for that? That's right.
That's right. And we inject some numbing into the skin, and then the biopsy itself is painless. If it's a melanoma, or for most inflammatory lesions, there's either a punch biopsy, which takes a deeper sample, which basically cores out the entire skin, the entire depth of the skin, including the epidermis, which is the uppermost layer, and the dermis, until the subcutaneous fat, or an excisional biopsy, which takes the entire lesion. If we have a suspicion of melanoma, often we'll do an excisional biopsy, which takes the entire lesion right there.
And so the patient may come in, you're suspicious, you will take it away completely, and
right,
in one go, as it were.
In one go, and sometimes we may have to come back and take wider margins, but at least we won't have left that patient with something that we think is more likely than not a melanoma.
Are there any blood tests or scans that would be useful, or is that not really appropriate in this condition?
Typically, in most cases, no. In most cases, that's not necessary.
You've mentioned three types of skin cancer: the basal cell carcinoma, squamous cell carcinoma, and the malignant melanoma. Can you just go through which would be the most likely to spread to other parts of the body, or which are more likely to stay local to the skin?
Sure. Basal cell carcinomas very, very rarely metastasize, almost never. It does happen, it's exceedingly rare. And certainly at the stage at which the vast majority of patients would bring the basal cell carcinoma to a doctor's attention, it has not spread. It has not reached that point. Reported cases of metastatic basal cell carcinoma are in patients who have left it beyond anything that we can even imagine. What it will do, the way that basal cell carcinomas can cause problems is they often sit in sensitive, problematic areas. They can be on an eyelid, they can be on a nose, and they can get into structures. They can grow down deeper, and get into nerves, get into structures that can cause problems.
And that would require further excision.
And that would require further excision. And if they're in the center of the face, theoretically they can track down the optic nerve into the brain, and that can cause issues even without metastasis. That can even cause mortality. So basal cells can cause real problems, but metastasis is usually not how it does that. Squamous cell carcinomas can metastasize, and typically, in most cases, in most healthy patients, they are slow growing, and it takes a longer time. Nothing in medicine is 100%. There are more poorly differentiated squamous cell carcinomas. There are variants of squamous cell carcinomas that do grow quickly. There are a category of patients called immunosuppressed patients, patients who are on medications that tamp down their immune system for whatever reason. Sometimes
they're more vulnerable to spread.
That are more vulnerable to squamous cell carcinomas growing quickly. And these are patients that should be followed very closely by a dermatologist, maybe especially patients who've had an organ transplant. Sometimes they'll follow them, several times a year with full body exams. And then there's I once heard a statistic that the mortality rate from squamous cell carcinoma is the same as that from melanoma, but there's so many more cases of squamous cell carcinoma that proportionally it's far less. And then there's melanoma, which is something which is a more aggressive type of cancer, where it's something that you really don't. We as dermatologists try to catch quickly. It's something that if we see it in clinic, we'll try to excise it that day, because these do tend to spread more quickly, tend to be more aggressive. There again, with melanomas too, there are different subtypes. There are lentigo maligna melanomas, which can sit for longer and without doing much, but there are nodular melanomas which can grow really quickly. But melanomas are aggressive cancers,
That's the ones that one has to worry about spreading.
Exactly. Exactly, and that makes up the bulk of when we talk about mortality. When we worry about mortality from skin cancer, that's melanoma is the bad actor that we think of.
Could you just briefly go through the current treatment of each of the main types of skin cancer that you've mentioned, and also how successful are they?
Of course, as we mentioned, an ounce of prevention is worth a pound of cure. So always the best that anyone can do is to prevent ultraviolet exposure and not have to undergo treatment. But once a skin cancer has developed, there are different stages in development of skin cancer. With squamous cell carcinoma, there's a stage called actinic keratosis, which is considered a precancer, in which there's usually it presents as scaly skin, which then can develop into squamous cell carcinoma of the skin if left untreated. That usually is treated with in various ways. There are creams, there are treatments with a certain kind of light called photodynamic therapy. Which is done in combination with a chemical that's applied to the skin. There are some lasers that are under investigation as well, and usually the treatment for those is non-surgical. If there's just a handful, we use cryotherapy. We'll spray them with liquid nitrogen, which is super cold, and that destroys the epidermis, which is the upper layer of the skin where those are found. Once we have a full-blown cancer, then, and certainly if it's invaded beyond the epidermis and gone into the dermis, the lower, the deeper layer of the skin, then the gold standard is to cut it out, to do surgery. And when it's on certain parts of the body, on the face, on parts of the body where you want to keep as much skin as you can and not sacrifice any of it, then the gold standard for treatment is something called Mohs surgery.
That's your specialty.
Which is my special.
Yeah. Could you give us an outline of Mohs surgery?
Sure.
The name especially is I found fascinating.
Sure. So Mohs surgery is it's named for the inventor of the procedure. His name was Frederick Mohs, right. Who was a general surgeon in Wisconsin who invented the procedure in the 1940s, and he came up with the idea of taking out a piece of skin where the tumor is, and mounting the piece in such a way that you could cut it and have the entire cut surface of the tissue on the same plane, and so that when you put it on a slide, on a pathology slide, the person looking at the slide, the pathologist, which in this case is the surgeon, can look at the slide and look at the entire cut surface and see if there's any cancer that's transected, any cancer that's cut, and that way can see if the slide is clear. That means that you're beyond where the cancer is, so you can tell during the surgery. Right.
So this procedure is done whilst the patient is in front of you. You'll get an instant report from the pathologist.
Actually, in Mohs surgery, the surgeon is the pathologist.
Right.
So in that way, you don't have to have a pathologist tell you, I see some tumor on at 3 o'clock,
yeah,
and sort of guess where it is. But the surgeon, I myself can say, okay, it's right there, and then I can mark it on a map and go back to the patient and take it out from where I've seen it. So that's the advantage of Mohs surgery. Typically, what's the alternative? The other way to take out to surgically remove cancers is what's called a standard excision. In that case, you would take some wider borders and take out a larger area and send it off to a pathologist who would make slides, and that would take. Usually you would send that out for permanent sections. That would take longer. You would close the patient up in between, sometimes you would get it all, sometimes you wouldn't. This way you can take very tight margins. You can have the confidence of knowing that day that that the tumor is all gone. It takes quite a bit longer,
sure.
But
I'm also aware of the fact that most patients, if they have a skin cancer, there will be the disfigurement issues or their worries about their appearance afterwards. Presumably the Mohs surgery helps with that as well.
Exactly. One of the because skin cancer is so closely associated with ultraviolet radiation and with the sun, we tend to get more skin cancers in those areas that we keep exposed to the sun, which are, of course, the face, the ears, the part of the scalp that's not covered with hair, the neck, the hands, sometimes the forearms. So those are the areas that are also cosmetically sensitive, the areas that people see. So those are the areas that we want to try to keep things small and to keep to be able to close them in the most cosmetically acceptable ways possible.
It's obvious that you're at the cutting edge of treatment here. Can you give us some idea of current research or current developments that are taking the whole treatment forward?
Sure. In the realm of skin cancers, there's been some exciting developments in the last couple of years. In melanoma, there have been a whole slew of new medications for treating metastatic melanomas that have sort of that have gone beyond the skin.
Spread to other parts of the body.
Right. And there's been more progress in the last 5 years than in the decades prior in terms of advanced melanoma. As far as basal cell carcinoma, in the past 5, 6, 7 years, there's a new class of drugs called Hedgehog pathway inhibitors that have also Hedgehog.
Oh, right.
That's the.
I'm fascinated. On you go.
That's scientists have all sorts of. I'm told that it's that the inspiration is Sonic the Hedgehog, which is a character from Sega video games, because it's involved in hair production. But so they've identified the genetic pathway that's associated with that's mutated in basal cell carcinomas, and they've created designer drugs to interfere with that pathway, and it's showing promise. There are some side effects. It's really being used now for advanced basal cell carcinomas, patients who have and the very, very rare instances of metastatic basal cell carcinomas, which are really vanishingly rare, and those that are inoperable, patients that have 10 or more. But it is something that's out there, and there are exciting new developments all the time.
So there's a possibility in, say, 20, 30 years' time that surgery may not be the treatment of choice for these conditions.
In medicine, we always hope that one day what we do will become obsolete.
Sure.
But
I think there'll still be a place for you to work with skin cancers.
That's right.
I presume also throughout your work you've dealt with people, for argument's sake, who've had malignant melanoma that's spread, that you reckon that possibly incurable, but have you had any surprises where they've actually made a good recovery from it?
So in my particular specialty, as a dermatologist and Mohs surgeon, I typically see patients who can be cured with surgery.
Yeah.
So when it comes to metastatic disease, that's typically referred to a medical oncologist.
Right.
And we do work very closely with them. But sure, with the new drugs, there are certainly more stories like that than there have been before.
Okay, so we've gone through the types of skin cancer, the treatment. So summing up, the main point I would take from this is if you notice any change in any part of your skin that doesn't seem right, you should get it checked out by a dermatologist. So that's self-surveillance. You've also mentioned there are high-risk groups like family history, and they should be even more aware, and possibly they should be checked out routinely by a dermatologist. That's, for argument's sake, every 6 months or every year. Is there any place for widespread surveillance of the population, or should that be left to the individual, basically, to look out for changes themselves?
That's right. You know, we recommend patients come in once, certainly every 12 months, to be checked out, for us to do a full body skin exam. Patients who are at a higher risk category should come every 6 months and at least have the sun-exposed parts of their body examined. And then there are higher risk categories than that, patients who have lots of unusual moles, patients who have a history of melanomas, especially in the recent past, patients who have strong family histories, who should be seen even more frequently by the dermatologist. And there are all sorts of other modalities that are available now. There's mole mapping, in which photos are taken of parts of the body. There's controversy as to, and it's still being worked out in the literature, as to what extent this prevents skin cancer or prevents is important in surveillance and detection. But all these tools are out there; they're available to patients, and people should know that they're available and should avail themselves of them. And again, protect yourself from the sun. An ounce of prevention is worth a pound of cure. And look, if you see something, say something. Come see your dermatologist. Tell us about it. Come to us before it gets to be too late, and we'll take care of it. We'll do the Mohs. We'll give you the. We'll keep it as small as possible. Give you the nicest possible result that you can have, and stay safe.
Thank you very much. Thank you.